And here we go. Chapter 9, Part 5, the Trauma Patient Assessment.
Unit 21, please respond to Brown and 4th Street at the park for an ill male. Scene is safe per all.
All right, why that's in there, I have no idea. So let's skip right past that video of the medical patient assessment and let's talk trauma. So I hope you've put together now that the patient assessment, no matter what's going on, no matter what has been injured, no matter what is ill, the beginning portions of our patient assessment are all the exact same. We do that scene size up. We want to make sure that the scene is safe. We want to make sure that we have our proper PPE on. We want to make sure that we have just the one patient or all the additional resources on scene that we need to care for however many patients there are. That includes things like the fire department, the police department, gas, light, electric, whoever, to make sure that the scene doesn't become unmanageable. And if at any point we decide that we need somebody, well, you use your radio, use your cell phone, and you reach out and touch somebody. After that, we move on to our primary assessment. Our primary assessment, whether it's medical or whether it's trauma, does not make one bit of difference. Our primary assessment is going to be general impression, level of consciousness and mental status. With our trauma patient, we want to pay close attention to make sure that we are not missing any gross external hemorrhage. So we start with that XABC. After we verify that we don't have any huge external hemorrhages that need to be addressed right away, we move into airway, breathing, circulation. Airway, breathing, and circulation do not change one stinking little bit. We are going to assess our airway. We're going to make sure that it is open, clear, and secure. We are going to do whatever we need to fix any problems that we find. Then we move to breathing. Breathing, rate, rhythm, and quality. Noiseless, effortless, and painless. When we find a problem with breathing, we fix a problem with breathing. For our traumatic patient, we'll talk, I believe later on this week, about some of the problems we may find mechanically with breathing that are going to need to be addressed right away during our breathing assessment. And I'll tell you how to figure out whether or not you found one and when you should find them. And we'll move to circulation. Skin color, temperature, and condition, rate, rhythm, and quality of the pulse. That's going to tell us, is my patient who has been exposed to this traumatic event either in shock or on their way to shock? I'm going to do one more gross hemorrhage check. I call it the sticky test, where I take my hands and I put them underneath my patient and I pull them out. And I'm just going through the big major portions of the body, looking to see if there's any blood pooling underneath my patient. After that, I make my transport decision. Business as usual. My patient's going to be a high priority transport to the closest appropriate facility with an ALS intercept en route. Now, there is one bit of change to our trauma assessment, primary assessment. Does anybody remember yesterday from Kevin's talk what that is?
Hey Tommy, are you clicking slides?
I haven't clicked any slides yet.
Oh, okay, just checking.
Nope, haven't moved a thing. Because our trauma assessment really gets to the jumping off point right at secondary assessment. So we're still going through scene size up in primary just to kind of reinforce some stuff. So somebody, what is the one new, fun, and exciting thing we're going to add to the beginning portion of our trauma assessment that Kevin would have told you yesterday?
Would it be a mobilization?
Say it again, Paul.
Immobilization?
Immobilization, yes. As we are approaching this patient and we see them laying supine on the ground, the very first thing, even before I say I'm going to start forming my general impression and look for gross hemorrhage, I'm going to instruct my partner to go and hold manual inline stabilization of my patient's head. So that way we are now taking C-spine precautions. We are making sure that if my patient does have a cervical spine injury, my partner is dedicated to making sure that we don't make that any worse. Then I start looking for my gross hemorrhage and addressing any gross hemorrhage I find. Then I start assessing my airway and treating any of my airway issues. Then I start assessing my breathing and treating any of my breathing issues. Then I get to circulation. And by then, I'm beginning to make my transport decision. So the only piece that we added really was checking to make sure and having my partner maintain manual stabilization of the patient's C-spine. Now with our trauma patients, and a term that I use that all my examiner friends that come in and teach with us really can't stand is trauma naked. So as we're making our transport decision, we are going to expose our patient. So if you can remember to just cut off all of your patient's clothing and use whatever terminology you deem appropriate to say that you've exposed your patient. If you don't want Sully and Kevin yelling at you, just say, I'm going to expose my patient. That's going to give us a very quick look at the mechanics of breathing, any other things that we might see that are non-anatomical, and we can ask about those questions. Because when we talk about chest trauma in, I believe, Thursday, two of the very most significant injuries we can find are going to be a flail segment in the chest. So we'll see some ribs moving paradoxically or opposite the way we expect them to when my patient is breathing. And that's an injury we have to treat right away when we find it during our breathing assessment. Or a sucking chest wound, which is another injury we'll find on the chest. And that is something that also needs to be corrected right away, so that we don't start seeing some obstructive shock and some tension pneumothorax. So during your breathing assessment of a trauma patient, tell the examiners, and get in the habit of looking for things on the chest. Now, I've always said, listen to lung sounds. So when you're listening, get in the habit of looking as well. I'm going to look at the patient's chest. Do I see anything? Do I see any? And then use the term paradoxical motion. That tells me that not only now do you understand, you're also applying and you're also figuring out all the dangerous, deadly things that you need to look for, and you're keeping yourself sharp and to the point, because primary problems should be found during your primary assessment and should be fixed right away. So that's kind of how we get through and make sure we don't find any problems with the mechanics of breathing. Because if we wait too long, that sucking chest wound turns into a tension pneumothorax, turns into obstructive shock, turns into a patient who's much sicker than they were when we found them. That paradoxical motion and those multiple broken ribs, broken in multiple spots, turn into a much larger deficit for our patient. And we could have fixed it early and been ahead of the game. So look, listen, feel for real. Like, actually go through the motions of listening to your lung sounds, looking at your patient's chest, touching your patient's chest. The trauma assessment of a significant mechanism of injury trauma patient is very touchy-feely. It is very much a physical examination. We do a focused history, sure. We're going to ask them things about the event. We are going to get, as much information as we can. But for right now, we are talking about the assessment of an unresponsive patient. So how much history am I really going to get? If my patient's not able to talk to me, my assessment becomes much more difficult. So I have to focus it on things that I can find, things that I can touch, things that I can actually put my finger right on and say, hey, this is probably a problem. Because we still don't have X-ray vision. My no significant mechanism of injury, pretty simple, pretty straightforward. My patient's going to tell me, hey, I fell, I think I broke my wrist, this really hurts. Okay, well, the story matches the complaint. Now I can go ahead and investigate this chief complaint. The history of present illness is going to tell me, well, how did this injury occur? Well, I hopped on my kid's skateboard, and the next thing I know, bang, broken wrist. Okay. Did you have a head strike? No. Perfect. I'm going to assess that broken wrist. I don't need to touch every single inch of my patient's body. I don't need to cut that person's clothes off because it's an isolated injury. We're not really thinking, holy smokes, this person's going to be, bleeding to death internally from their wrist fracture that they had when they struck the ground with just their hands and broke one wrist, as opposed to when my patient really fell off a ladder off the roof of their house and multiple points of their body struck the ground. Multiple injuries can be expected. So our trauma assessment is very different depending on how smashed up our patient is. We're going to look at the nature of forces involved. Our intro, well, not intro to trauma, our trauma overview is going to get deep into that. We start thinking about the direction and strength of forces that are applied to the body. Was there any protective equipment used? So things like motorcycle helmets, sporting equipment, or, as simple as just general everyday wearing a helmet when you ski. Those kinds of things will actually minimize the amount of force, minimize sort of the negative impact of striking a solid object that the body hits. Actions taken to prevent or minimize injury. Sometimes people are able to, tuck and roll rather than coming down flat when they, when they know that something is coming. Other times people fall down and just as dumb luck would have it, their squash hits every single stair on the way down. I mean, trauma is an unexpected thing. It's not something that's very easily prepared for. That's why they're called accidents, But take your time and go through, especially with someone we think hasn't had a very significant mechanism of injury. Take your time and assess areas that they complain about. Just because they have this one glaring spot that is painful doesn't mean that something else isn't hurt as well. We'll see when we talk sort of the force of gravity and all of that good, fun, happy stuff in the next lecture, that just because a particular spot is what came to rest against that force doesn't mean that that direction and strength of the force wasn't transferred and transmitted to somewhere else. A lot of times if we see people that fall from a height and land on their feet, yes, their heel bones are oftentimes broken, their ankles and lower legs might be a mess, but a lot of the times we'll see things like lumbar spine fractures and hip and pelvis injuries just because that shock wave of force gets transmitted up through the body. A physical exam, yes, depends on areas of chief complaint, the mechanism. We're going to inspect, palpate, and auscultate. So inspect means we're going to look. We want to know, is there anything asymmetrical about this extremity or about this injury area compared with the other side of the body? Really, we are mirror images of ourselves if you cut us right down the midline. So each side of the body, respectively, should kind of look similar. If we see something that is different than that, well, we obviously know we found a problem. Other things that we're looking for are changes in color, shape, or movement. If an extremity injury is discolored, that's problematic. That starts leading us to, is there possibly some compromise with circulation, sensation, and motor function, distal or further away from wherever that injury actually happened? Shape is a big one. Things that are misshapen aren't really my favorite thing to look at. arms and legs and things weren't meant to bend in wrong directions and weren't meant to have bends where there aren't actually joints. So when we see something like that, 2 + 2 being 4 in all, our patient has an issue. There are times where extremities will become totally immovable based on the traumatic event that our patient was involved in. The onus really isn't on us to decipher and decide and make a real solid diagnosis of what the injury itself actually is. We are just looking at things and trying to decide, is that normal? Is that abnormal? And is there anything I can do about it, really? We do, when a patient has what is known as a painful, swollen, and deformed extremity, aka fracture, if there is no actual pulse in the distal portions of that extremity, you will actually make one attempt at pulling some gentle traction to restore a pulse to the distal portions of that extremity, because the amount of tissue damage that can be caused from that is just astronomical. We need to have oxygenated blood flow to every area of our person. If we can't realign the injury, we don't force it. If we can't restore a pulse, we don't keep trying, because it's a sign that maybe some vasculature in there is damaged and we don't want to worsen any of that blood loss, but we do make that one attempt to try and restore a pulse. Then we'll just apply our splinting material as we're able to, and life goes on. After our inspection, we're going to palpate. We are actually going to look for something very specific when we get into it here in just a minute. We're looking and feeling for any abnormalities in shape, temperature, texture, or sensation. So is the skin in the distal portion further away from where this injury happened starting to feel cool? Is my patient having a difficult time wiggling their fingers? Am I having a difficult time locating a pulse? Is it maybe getting a little weaker? Are they complaining of some paresthesia? That means pins and needles. And these are all things that I'm actually going to physically put my hands on. And our auscultation really is sort of limited to the chest. We are going to auscultate for lung sounds. That will tell us if our patient is developing a pneumo or a tension pneumo or a hemothorax. So we'll hear some diminished lung sounds on the affected side if we're auscultating and think that we're starting to hear a developing chest problem. Diminished lung sounds or absent lung sounds mean it's quieter on one side or completely quiet on one side, and the other side will sound normal. So when we're doing this inspection, palpation, and auscultation, here all is what we're looking for. I'm sure Kevin used this term yesterday, and it is a DCAP BTLS. These are all the different soft tissue and bone injuries sort of in one long mouthful of words that we're going to be looking for when we're palpating our trauma patient. So we're looking for deformities, contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. So just as a forewarning, there are some pictures coming up, so be advised. So deformities, that's pretty simple. Things that don't look the way arms and legs and fingers and feet and toes are supposed to look. Contusions are just bruises, but they are really a lot of times bruises on a little bit bigger of a scale. Abrasions, think things like road rash or rug burn. You're not really talking deep injuries, but it's almost like a layer or two of skin has pretty much been practically sanded off by friction on your patient. This is big in like motorcycle crashes and things like that. Punctures and penetrations, also pretty straightforward. Anything pointy that goes through our person is going to cause a puncture or a penetrating wound. Burns, also pretty straightforward. When heat is applied to skin, skin does not like it. So burns are a traumatic injury. Tenderness, if I touch and my patient goes, ow, stop that, that hurts. Well, there we go. We found some tenderness. Next on our list is lacerations. Lacerations is just fancy medical speak for a cut. And swelling. When we compare the sides of the body again, if we are looking at fingers or a wrist that are just completely different sizes from the non-injured side to the injured side, we know that we have found some swelling. Soft tissue injury associated with some of these traumatic events is going to cause some swelling. We're going to have some inflammation. We're going to have some fluid leakage. We may have some bleeding, and all of that going on in and around the tissues is just going to cause some swelling. So as we're palpating every single area of our trauma patient, we are going to say, I'm looking for DCAP, BTLS, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. And I promise you, both in the classroom with me and at the exam, you will probably say that 2 times before I will tell you to knock it off. Once you've shown me that you know what you're looking for and where you're looking for it and how you're supposed to look for it, I'll take your word for it. So deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling is what we're on the hunt for during our physical exam. Picture time. Here's a deformity. We have a clear problem with the integrity of the structure of this arm. There is not supposed to be a bend there, and there is. No es bueno. Next, we have punctures and penetrations. This to me looks like it's probably some sort of small caliber bullet wound. I say small caliber because it's not in my person. Anything and everything that penetrates the body is going to be a puncture wound, period, end of days. Next, swelling. This kid's got a pretty nice sized speed bump right in the middle of his forehead. And who knows what caused it? Not really that big of a concern. Not for us anyway, because this is a picture. If this was my patient, clearly the underneath got a pretty significant shock wave, because whatever caused a lump that size was a pretty significant head strike. After we have evaluated our patient for our baseline vitals, our DCAP BTLS, and we've checked out their chief complaint and any associated body parts and looked to make sure we're not overlooking something else that's been injured, we're going to get our baseline vital signs. So we've at this point completed our secondary assessment. We're getting our baseline vitals. We are going to look for all the same vital signs as we would have on a medical patient. If my trauma patient is awake and responsive and answering questions and they make sense, I'm going to obtain their past medical history. So I'm going to go into that sample. Why do you think I obtain a sample history on a trauma patient?
To see if they worsened something they already had before.
Yes, all right, cool. We could have exacerbated some sort of other problem in their medical history, especially with an elderly patient. We could hear something like osteoporosis or, spinal stenosis. So now I'm thinking, all right, well, grandpa probably crumpled like a paper bag when he hit the ground. So this probably is much more negative than I had initially given it credit for. And also, I need to know, what do you take for medicines? What do you have for a medical history that may complicate and confound and really make all of this possibly a bit worse? So I still look at those same signs and symptoms. I'm just running it back to make sure I didn't miss anything. I want to know if you have any allergies. I want to know if you take any medications. I want to know if you have any pertinent past history. I want to know your last ins and outs, because correction of significant trauma And sometimes even trauma that doesn't have a huge mechanism of injury is surgical. So trauma is a surgical disease. If my patient's going to wind up in an operating room, they're going to want to know, is this patient going to be filled to the brim with lunch? And that's going to present a problem for us. I also want to know the events leading up to whatever it was that happened, because that's going to tell me, was there a medical problem involved? I was having wicked chest pain and I felt lightheaded and dizzy, and I stood up, and when I stood up, I don't remember what happened next, but the next thing I knew, my head was bleeding and I was on the floor. Okay, so now we possibly can wind this back to a traumatic event that was caused by a medical issue, and now we have two separate problems, like which came first, the chicken or the egg? Was this patient having a heart attack, and then when he stood up had a syncopal and whomped his head off the counter? Or was he just, average, not feeling well? And is any of this significant? Well, the answer is yes. Our baseline vital signs are wonderful because they are both subjective and objective. I'm going to be looking for anything I see, hear, feel, or smell during my physical exam, so my secondary. You get used to using all of your senses when you're assessing a patient. Sometimes patients just don't look right. I'm going to collect my vital signs. That gives me my measuring stick. I can actually physically record and monitor what is going on inside of this person. Now, if somebody was just involved in a traumatic event, what might you expect out of their vital signs? What might happen?
Elevated heart rate.
Yeah, elevated heart rate. What else?
High blood pressure.
Yeah, their blood pressure could go up. Anybody ever been involved in a car accident and could hear their heart beating in their ears because they were mad? We have that same epi response. And if your body hasn't been insulted to the point where that epinephrine needs to save it, that epinephrine is just going to drive their vital signs up. So we'll see maybe some pretty significant hypertension, a pretty rapid pulse rate, a pretty rapid respiratory rate. But we won't see a lot of the systemic type problems as far as pale, cool, clammy, sweaty skin, cold hands, because the patient's not actually leaking. So we may see those same signs of an epinephrine response, but my patient is still healthy and doing well. They just, they broke an arm or something in the car accident, or when the airbag went off, it hit them in the face and broke their nose, and now they're just mad, and they have all this epinephrine running through them. When we start to see some systemic type problems, like things that point me towards hypoperfusion, then I start wondering, all right, I see all these elevated vital signs, and my patient was just involved in, now we'll say, a pretty significant trauma. And now I'm starting to see things like shock-like symptoms, maybe some altered mental status, maybe just some jitters. So they're not quite altered yet, but they're difficult to pin down and they're just going a mile a minute. And, I'm getting a rapid pulse and a rapid respiratory rate. And then maybe the blood pressure is sort of normal-ish, maybe a little low. And then what am I starting to think if I find vital signs like that?
Patient is decompensating.
Yeah, they're beginning to get sick. If I find a patient who's just involved in a trauma and everything spiked because they're lit up like a Christmas tree, that makes sense. If I see a patient now who was involved in a pretty significant trauma and heart rate, respiratory rate are up and blood pressures didn't go with it, well, that means they're probably leaking somewhere, even if I haven't found it yet, or even if I never find it. Until I get them dropped off at the emergency room, I am going to treat them like they are in shock, because to me, they presented to me like they are in shock. And shock is only going to get worse. We've seen that So we get out in front of it, lay them flat, oxygenate them, keep them warm, and get them transported, because at the end of the day, traumatic events are treated in hospital. We're not going to really make much big difference for a trauma patient other than to get them transported somewhere that can put the broken bits back together. Sample history, we already did that. When you come in today, we're going to practice measuring cervical collars for each other. So we'll be able to figure out how to do that. I'm not going to get into that too deeply here because we'll spend some time on it today. Let's see what this video has to tell us.
This video will demonstrate the technique of measuring, sizing, and applying a cervical collar. While this video shows a particular brand of cervical collar for demonstration purposes, the principles of sizing and application remain the same regardless of the product chosen for use by an individual service. It is the responsibility of each provider to be familiar with the specifics of the product in use in his or her service. The first provider initiates manual neutral inline stabilization of the patient's head and neck. The second provider uses his or her fingers to measure the distance between the patient's lower jaw and shoulder. The provider uses this measurement to select a properly sized collar or to set an adjustable collar to the correct size. If an adjustable collar is used, the provider must make sure the collar is locked into the proper size. The second provider applies the properly sized collar, while the first provider maintains the neutral inline head and neck stabilization until the patient is secured to an immobilization device. Specific patient populations, such as extremes of age and size, may require additional padding and support in order to maintain adequate alignment and comfort.
Thrilling, magical. Moving on. So at this point, we have talked about people who weren't really altogether that injured. Yes, they have an injury, but we're talking isolated, simple trauma, something that is not a patient who looks like they've been run over by a dump truck. Like that was all pretty easy, isolated, no fuss, no muss. With our significant mechanism of injury trauma patient, things change a little bit. Significant mechanism of injury says to me that I expect way more than just isolated injury. I expect that my patient can have injuries that pop up absolutely anywhere throughout their person. So this is where I do a complete rapid head to toe rapid trauma exam. Now, rapid means just that. This type of secondary assessment is the one we're going to practice here in class, because a verbal assessment of somebody who's got an isolated trauma is no real different than our medical. Now, this is a patient who I am going to rapidly, after I do my scene size up, my primary assessment, my secondary assessment of this patient is fast. This is that one where I palpate the bones of the skull, looking for any deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. I'm going to palpate the bones of the face, looking for any tenderness, distension, deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. And I run through that on every single area of the body. I look for any tracheal deviation. I look for jugular vein distension. I check around the back of the spine. I'm looking for step-offs or any deformity. I apply my cervical collar with my patient laying right there, supine on the ground, and then I move along. I palpate, inspect, and auscultate the bones of the chest, looking for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling. And then I palpate all 4 quadrants of the abdomen. In the abdomen, I'm looking for the same 4 things that we talked about yesterday: tenderness, rigidity, distension, or guarding. And then I move on. If I find something during this rapid trauma assessment, should I be fixing it as I go?
I'm just gonna put it out there, but your partner should be there too, right?
Well, my partner's going to be holding stabilization till we get this patient on a backboard.
Right.
But I found, or should have found, all of my primary, very, very deadly problems right in the very beginning. So I fixed my primary problems during my primary assessment. Those are the things that are likely to kill this patient right now and I can have the greatest amount of effect on. If I'm poking and prodding and touching, and even if I'm finding stuff, can I fix a depressed skull fracture? Can I fix broken fingers, toes, and bones anywhere in between?
No.
No. So what this rapid trauma exam is really meant to do is find all the areas on the body that are injured. Unless we find something that didn't rear its ugly head during our primary assessment, so unless we find something that got overlooked during our primary assessment and may likely kill our patient, we don't fix it during this rapid trauma. This rapid trauma is just that. Think of it, you are kneeling in the middle of the street and really just trying to get a bird's eye view of what is all smashed up on this person. Because the next thing we do after we finish this rapid trauma assessment is we roll them up on their side, examine their posterior every bit as much rapidly, put them on a backboard, load that backboard onto our stretcher, and load that patient into our ambulance. But I've already finished my rapid assessment, so I know where all now the secondary broken things that I found during my secondary assessment are. So when I start reassessing this patient and go back and check their airway, breathing, and circulation, and go back and recheck their vital signs every 5 minutes because they are a unstable patient. In between all of that reassessment, that's when I fix all of these secondary injuries. Why do I wait until we're in the ambulance and rolling? Anybody? Somebody just toss out an answer.
Because it's priority transport.
It's a priority transport. If I stop and put a Band-Aid on every owie right there kneeling in the gutter, I'm taking time. And time is something that a trauma patient, a significant mechanism of injury trauma patient, does not have. Remember, our goal, we talked about this very briefly yesterday, our goal is on and off scene in less than 10 minutes. We don't have time to fix every little spot that has a bit of road rash, or splint those broken fingers with a popsicle stick and all that stuff. I can do all that when I'm rolling towards where definitive care and final treatment is going to be. I can do that as we are on our way to a trauma center to get these broken bits and pieces put back together so that my patient doesn't look like a puzzle with pieces missing. So
Hey, Tommy, I have a quick question.
Yeah.
So as an EMT, obviously, if somebody dislocates their shoulder, dislocates something, we're not qualified to pop it back in. But as a paramedic or anything, are they qualified to do that, like right on scene?
No, actually.
So like, how do you? Is it bad if someone dislocated something and you don't like a shoulder, you don't pop it back in like soon enough?
It can be most of the time, and that's part of the reason why we do, and we'll talk more about this in just a little bit. But when we find an injury, right? So let's say we have that isolated shoulder dislocation. That's why we are always going to check circulation, sensation, and motor function distal on the extremity. So if we have a shoulder injury, I'm going to check a radial pulse. I'm going to make sure that my patient can wiggle their fingers. I'm going to make sure they can tell me exactly what finger I'm touching when I'm touching it, because that will tell me that blood flow and nerve messages are getting to and from the faraway parts of that extremity. So if those things are all still in place, timing isn't necessarily super important to get something reduced.
Mhm.
Typically they do it right away, just because the longer you let that joint be unstable and the muscles kind of only free floating and not doing what they're supposed to, a lot of times, first, the more difficult it is to get back in, and second, it doesn't hold together quite as well, so it happens more often. But yeah, no, don't get in the habit of that if it can be avoided. I mean, some people have shoulders that they sneeze and it pops out of socket.
Yeah,
And
that's what I was thinking, because like they happens all the time, so it's like, doesn't it feel better if they just pop it back in?
oh, it does, but there's a lot of stuff that, makes sense for us, but you also have to think of what else is hurt, what else could this cause? Could putting that shoulder joint back together actually somehow compromise circulation, sensation, and motor function, because we can't see the images. So we don't know if there's something sort of in the way, and are we going to make it worse?
So
Um,
if you brought them to a hospital and is the doctor's first priority, it's not to pop it back in.
nope.
It's to get a scan of it.
First priority really would be to verify that there is still adequate blood flow. Next would probably be to medicate, because the patient's likely to be absolutely screaming. And third would be to get a scan and figure out what they can do with it and what does it need as far as advanced level treatment. As long as there's blood flow, they're not in a rush. Is really,
Okay.
yeah. If there's no blood flow, we're in a hurry, and we're going to try and fix it once. We're not likely to be able to, but so our rapid trauma assessment only requires a few moments. In class, touch and talk about everything. Verbal diarrhea is what we're looking for. I want you to say all sorts of things, what I'm looking for, what I'm touching, where I'm going. Um, in actuality, when you guys start doing this on the road, you're going to do all of the same things, but your rapid trauma assessment can really be accomplished in under 90 seconds. This is meant to be super fast, and just make sure I didn't overlook anything that's going to kill this patient, and then I'll fix all of the other smashed up bits and pieces as we move along. Your rapid trauma assessment does need to be performed at scene, because we are still looking for some of those hidden, possibly deadly injuries that maybe didn't pop right up or jump right out at us when we did our primary assessment. This rapid trauma assessment is going to sort of guide the care that we're going to do en route, because sitting there and sort of touching and feeling and getting all of our information is good, but thinking that we're going to cover and put ice packs and put band-aids and do all of that stuff to someone who is really on the clock and doesn't have time for us to be farting about is really not the best use of what our patient has left for time at that given moment. We're going to touch everything: head, neck, chest, abdomen, pelvis, back, extremities, and then we get our baseline vital signs. Then is when we'll try and get our sample history as well. We just work our way through all these things and work our way through them quickly. We're looking for that DCAP BTLS or any other abnormal findings. So step-offs in the spine mean that the spinal cord is, or the spinal column rather, is no longer sort of a nice, straight, smooth flowing line like it's supposed to be. We find things that look like a staircase, and that is not good. Means our patient's having a bad day. We're just looking for anything abnormal. So tenderness, rigidity, distension, and swelling in the abdomen, maybe some guarding, would also be a significant pathologic finding. We are going to expose areas before we examine them, because again, we want to inspect, palpate, and auscultate. So we are looking, listening, and feeling. We want to communicate with our patient. Even if they're I talk to unresponsive patients all the time. all the time. I probably look and sound like a complete and total buffoon, but I don't know if they can hear me or not, so I might as well chat with them. Always, if it's a significant mechanism of injury, we're going to assume that there is spinal injury. So we want to go ahead and take those C-spine precautions, like I said, right in the very beginning. If something happens and our patient's condition takes a turn for the negative, stop what you're doing and go fix it. If you all of a sudden your patient loses their airway, go make sure that that airway is open, clear, and secure. Or if you start to hear some gurgling, or your partner who's holding C-spine says, hey, I can see blood in the airway, stop what you're doing, go suction that airway, make sure the airway is open, clear, and secure, and go back. If your patient goes into respiratory failure or respiratory arrest, stop what you're doing, get a BVM, go fix the problem, go back to what you were doing. We're going to look for cerebrospinal fluid leaking out of the ears or the nose. Cerebrospinal fluid is generally a clear to yellowish tinged fluid that will come out with blood if the patient has a skull fracture. We're going to look for unequal pupils. We are going to look for that jugular vein distension and tracheal deviation. Those two things are very, very late signs of tension pneumothorax and cardiac tamponade. If you start to see jugular vein distension or a trachea that is no longer midline, work faster. When we examine the chest, we're looking for that paradoxical motion. We're going to listen for crepitus when they breathe and when we palpate. Now, crepitus is a bit of an awful noise. It is the sound that bone ends make when they sort of rub together. It's crunchy. It sounds a little bit like stomping on a box of Rice Krispies, or almost like a grating sound. Like it's not nice. It's gross. We're going to look for unequal breath sounds. We'll look for any distension in the chest that actually points us towards some free-floating air and possible tension pneumo. We're really just on the hunt to make sure that the parts of this patient's body that are keeping them alive continue to function the way that they are supposed to. We palpate all four quadrants of the abdomen. When we examine the pelvis, we are going to look for a priapism in male patients or unexplained vaginal bleeding in a female patient. And when it's a trauma, any vaginal bleeding would be unexplained. Priapism is a painful erection that happens after a spinal cord injury or after a head injury. It's persistent. It doesn't go away. It is just there and hanging out. And really, after being involved in a trauma, it would be sort of a weird time to be, that happy about life. So check that when we look in the pelvic area. We are also going to push in on our patient's hips and pelvis, and then we will push down on our patient's hips and pelvis. If we have a problem when we push in on the pelvic girdle, you don't actually have to push down. Once we have found that the hips or pelvis are unstable, we're not going to go ahead and assess that again. We just go ahead and say that it's unstable. When we get down to the extremities, both hands and feet, we're looking for distal circulation, sensation, and motor function. So we touch all the way down to the ends, and when we get to the ends, we check a pulse, tell our patient to wiggle a finger, grab a hold of one of those fingers and ask them which one you're touching, and they'll go ahead and tell you if they can, and if they can't, it's a significant finding. When we log roll our patient up, we're going to run the entire back. We're going to check the posterior, the buttocks, and the back of the legs and arms, looking for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, swelling, any bleeding, tenderness, rigidity, or distension. We just go bang, 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 and look for all the same things in all the same areas. Hopefully we don't find any. If we do, okay. If we find a bleed or a pretty gnarly looking injury at this point, once we roll that patient onto a backboard, we do not get another chance to fix a problem that we find here. So take a quick second and, cover up a laceration or a penetrating wound that you find here, or do what you can to at least bandage and dress a wound that you find here as best you can. Because when you roll them back down, putting them back on that wound is actually going to apply some direct pressure to it. So we will slow down some of the bleeding. We just won't get a chance to poke at it again. So now's the time.
Patient assessment. Secondary assessment. This video will demonstrate the completion of a secondary assessment as part of a patient assessment. Obtaining baseline vital signs. If no critical findings are identified in the patient during the primary assessment, then you should continue with the secondary assessment. In a critical patient, start the secondary assessment during transport if time and the situation allow. Never delay the transport of a critical patient in order to perform a secondary assessment. The first step in performing a secondary assessment is to obtain a baseline set of vital signs, which includes the patient's pulse rate, strength, and location are measured for 15 seconds at a minimum. The patient's ventilation rate and depth are measured for 15 seconds at a minimum. The patient's blood pressure. The condition of the patient's skin. Sample history. Next, obtain a patient history from the patient, family members, or bystanders. The sample mnemonic is a useful tool when gathering a patient history. SAMPLE stands for signs and symptoms, allergies, medications, past and pertinent history, last oral intake, events leading up to this situation. Whenever possible, a complete and systematic head-to-toe physical examination is performed. This portion of the secondary assessment is adjusted and completed based on the patient's signs and symptoms and the mechanism of injury. During the head-to-toe physical examination, palpate, visualize, and auscultate the following body parts as indicated: head, neck, chest, abdomen, pelvis, back, upper extremities, lower extremities. During palpation, continually check your gloved hands for bleeding. In pediatric patients, reverse the assessment. Start at the pediatric patient's feet and move up. Next, perform a detailed neurologic examination that includes the Glasgow Coma Scale. If the patient's condition warrants, cardiac monitoring and pulse oximetry may be included as well. Finally, package the patient appropriately for transport to an appropriate facility. Provide spinal immobilization as necessary based on the combination of the patient's mechanism of injury and the findings of the secondary assessment. During transport, reassess the patient's vital signs and compare your findings to the patient's previous results.
So really, that was pretty solidly done. That was really what it looks like. Now, here in class, I expect a little bit more from you guys, and I expect a little bit more talking, but we'll get through it. I'll show you guys today sort of what we're looking for and how it should be done for our purposes here. But that was really, other than they didn't roll the patient, a bird's eye view of what it's supposed to look like. So somebody out there, tell me, what criteria would you use to decide whether to perform a focused exam or a rapid trauma exam? What's gonna point me towards needing one versus the other?
If you can see an injury, you do a rapid.
Okay, yeah. If I can see an injury, I'm thinking, all right, that's pretty significant. Like, for the most parts, our bodies are pretty rugged. They're meant to take a licking and keep on ticking. So if I can see something as I'm approaching that's like, oh man, that's awful, sure, I'm probably going to think that there's been a pretty significant amount of force applied to this person. What else? I was just about to start giving away all the answers, but I'm not, nothing's free today, so let's hear it.
If you pull up on a scene and you can't see an actual injury, but you have an unconscious patient, you would do the secondary checking for sticky stuff.
Yep, so yeah, our rapid assessment is going to be used for unresponsive patients, patients that we just look at it and go, why aren't you hurt worse? Well, the reason that they're not hurting worse or in worse shape generally can be tied right back to epinephrine. The body's just absolute defense mechanism against things that are scary, and traumatic events are that. So if you look at the scene or listen to the mechanism as you're getting your info, and you think, boy, you should be a lot more screwed up than you are, maybe it's time to start taking a bit of a deeper look. If my patient's conscious and alert and speaking to me and says, I stepped off the last step of my deck, I forgot that I had just put in, higher patio flake stones, and I heard a huge pop in my ankle. All right, well, I'm not cutting your clothes off and gonna start, with palpation of the bones of your head, face. You didn't even tell me you fell. You heard a huge pop in your ankle. You could have sat down. All right, that's isolated. I'm only thinking one body injury, one body area, one body system, and I'm not nearly as concerned as I am for the patient who just took his car into a tree, but is still up sort of buzzing around the scene, but looks kind of crummy. Their car looks like a complete and total disaster area. And now I'm sort of, my spidey sense is tingling a little bit, and I'm wondering, why aren't you in worse shape? When we are talking pediatrics, smaller patient, so a lesser mechanism of injury can cause much more significant damage. That's why we don't, say that children who fall from 20 feet, like we do adults, have sustained a significant mechanism of injury. We say children that have fallen 2 to 3 times their height have fallen and had a significant mechanism of injury. If your pediatric patient is conscious and alert, explain things a little bit more thoroughly, let them know what you're about to do, and start your assessment down at their feet, because getting up in their face and being all in their business is not going to win you any friends. Our detailed physical exam is going to be completed en route to the hospital. It's getting all the rest of our additional information. It's going to be a complement to our primary and secondary assessment. It is where we check out the primary assessment again. So we're going to do a bit of reassessment during our detailed physical exam. We're going to assess the injuries that we found during our secondary assessment a bit more deeply. This is when we will actually go through and treat those secondary injuries, because we're rolling. So we are on the way to definitive care. So now anything that I do is just bonus. The detailed physical is only performed after all critical interventions are done and locked in. So if you are constantly maintaining this patient's airway, or constantly having to ventilate this patient, or performing CPR, sorry, you're not going to get to, the Band-Aids on the fingers and, splinting their broken wrist. Your backboard will operate as a full body splint. It is considered a full body splint because that patient is, quote, fully immobilized. So we've done that. If you are still working critical stuff, don't get caught in the wash and start working on stuff that isn't really altogether that important and isn't really going to help make this patient live. we already covered. That's not a great question. All right, let's call that a wrap. So does anybody have any questions about a trauma assessment? All right, sold. All right, trauma overview. When we speak about traumatic injuries, some of the things we need to understand are the forces that are being applied to the body during any given traumatic situation. Since we do not have X-ray vision, the kinematics or kinetics of trauma is going to allow us to predict injury patterns, especially because at times trauma patients will wind up unresponsive or altered. Being able to predict what might be injured based on these next few things here, our mechanism of injury, the kinetics of trauma, the kinetic forces applied to the body, and the energy transfer from the body to the object or from the body to the ground is going to tell us some significant information. Realistically speaking, it is bodies in motion tend to stay in motion until acted upon by another force. So how severely a patient is injured is going to depend on how much force they are being propelled with when they strike something that is not going to move. That kinetic energy transfer from the patient to the object, say as in whatever this car hit or was hit by, is going to actually be transferred into the person inside. Now, you look at this car and it looks like a complete and total mess, right? Clearly, that's not driving away. Cars today are actually designed to look like complete and total, just terrible, terrible things happen to them in an effort for the car to actually soak up some of that kinetic energy. You know, back we used to, have these giant big hunks of metal that, looked like there was no crash at all. And the people inside looked like they had been put through a blender because all of the people that were inside actually absorbed the force. The car was this big honking piece of metal that didn't really bend and smash up. Whereas now we have cars that are built to do just the opposite. The car is supposed to take the hit and the people are supposed to be okay. So kinetic energy is mass times velocity squared, all divided by 2. Really what we're talking about here is still that however fast something is going and however much it weighs has a significant impact on both the force that is applied to that object and the force that is applied to that occupant. It is just astronomical the amount of damage that can be inflicted just based on speed. Speed alone in a 2,000 pound or 3,000 pound vehicle is going to propel that at just ridiculous proportions to the body. The law of inertia is that a body at rest will remain at rest and a body in motion will remain in motion. That is what we were talking about when I said the person is going to get a lot of that energy transfer. That car is moving towards that tree at, we'll say for argument's sake, 40 miles an hour. That means the person inside that vehicle is being propelled forward at 40 miles an hour. The person doesn't just stop when the car comes to that abrupt stop. The person will continue to move forward at 40 miles an hour until either the seatbelt restrains them or something inside the car stops them. So our unrestrained passengers who, cause deformity to the steering wheel or punch a hole in the windshield with their head, their chest deformed that steering wheel by hitting it at 40 miles an hour. Their head hit that windshield at 40 miles an hour. So we can start to think of some of this energy transfer that we've talked about and think about, all right, the head was the primary point of impact. But what's the head connected to? Well, the head bone's connected to the neck bone. So we start thinking, all right, maybe there's some neck injury. Then we get to the chest and we see that deformity to the steering wheel, and we think, all right, so we could have injury to the mechanics of breathing. We could have pretty significant injury to the ribs and the intercostal muscles. But then think about all those structures that are underneath. We have the heart, the lungs, the great vessels, to a certain extent, even the upper portion of the liver. And we start thinking, all right, well, all of that was also being propelled ahead at 40 miles an hour and then hit the inside of the patient. So now we start thinking, all right, what kind of internal injuries might I see based on just the sheer fact that this patient was booking when they hit that tree. And when they hit the tree, the patient still continued to go forward until something caused it to decelerate. Energy travels in a straight line unless it meets interference. That interference is going to be whatever stops it. Energy then changes its form and is transferred into whatever it was that it hit. That's why we will see such massive and internal injuries when we do see patients who strike steering wheels or strike windshields or get tossed about inside their car as it's rolling over, because there are really some significant impacts that we're going to talk about here, because there's 3 of them involved in every single collision, whether it's a vehicle collision, whether it's a collision with the ground. It doesn't really make any difference, because we go right back to the laws of motion, and whatever is in motion will stay in motion until acted upon by another force. So we have the initial vehicle collision, which is going to propel our patient forward. Then we have the body collision. So that's my body hitting something inside that vehicle. Then we have the organ collision on the inside, with my organs coming and hitting the internal structures of my body. And we also can add the fact that after that happens, I'm probably going to be slammed into something else and start this whole process all over again. Just the amount of mechanism there is in even a simple, not necessarily super duper high speed car crash or motor vehicle collision, to be more appropriate, I guess, is staggering when you think of all of that energy being transferred into this person. So first and foremost, we're going to talk vehicle collisions. I know a lot of this has sort of already been geared to that, but we need to think of really all of those things when we think any mechanism of injury. So it doesn't really matter if it is a fall or a fall from height or a fall down a flight of stairs, or if it is someone who's been assaulted with a bat or a brick. We have that initial collision of the brick with the head. We have the collision of the head and the brain together. And then we still have all those same forces, because now the patient's probably going to fall over. So now we don't even just see injury at the point of impact. We see injury at the point of impact again with the ground or other things that they may strike. Some things that really are going to make us very, very concerned when we show up to a motor vehicle collision. First of all, speed of travel. Speed of travel is going to give us a very high index of suspicion that somebody inside that car could be pretty mangled up. Other things, death of another occupant in the car. Why do you think I use that to sort of ratchet up my level of concern?
Because if they were injured bad enough to be killed, then your patient probably took a pretty good beating himself.
Yeah, right. If the other person was killed, why is this person still alive? They were both exposed to the same amount of force. So you really have to start thinking, all right, this patient is, even if they're not outwardly right now exhibiting all of the signs and symptoms and things that I expect them to, why aren't they? And really, it could just be simply based on the fact that they aren't yet. It is still the body compensating for itself, and maybe they have better ability to compensate for shock than the other person did, and the other person expired, and this person is just well working their way towards that. If we show up on scene and our patient is unresponsive or has an altered mental status, that concerns me on a couple of fronts. You know, was there some sort of direct insult to this patient's brain from the forces applied? Okay, that's bad enough. Or is this patient unresponsive or altered because they're hypoperfused, and I need to figure out the wheres and what fors of that as well. Intrusion of 12 inches or more into the vehicle, that means is the outside of the vehicle pushed in a foot or more to the inside of the vehicle. That is on the occupant side. So like this car door here, we probably do have 12 inches of intrusion. That would be if clearly someone was driving this vehicle, so that would be significant for the driver. If there was 18 inches of intrusion onto the passenger, so now if there was somebody on the passenger side and the driver's side gets pushed in by 18 inches, now we're thinking significant as well. If your patient has been ejected from the vehicle, generally speaking, patients that are ejected are just likely to not only have multiple gross injury patterns, but they are also about 75% to 80% more likely to die. You know, ejections, even partial ejections, really aren't good. We have very different types of car collisions. So we can predict injury patterns based on what type of crash it was. A frontal impact, especially a frontal unrestrained impact, we expect head injuries. We expect lower extremity injuries to the pelvis, knee, hip, femur, because the head is going to strike. The head is going to hit either the dashboard or the head is going to hit the windshield. But the legs and the lower extremities are also going to come forward and hit a solid object inside of that car. So we start to see some injury to the knees. Maybe the knees hit hard enough to actually blow the hips right out of the socket and dislocate them. Maybe they break the heads right off the femur completely and just break that hip. If a patient is restrained, like this lap belt patient, but not restrained appropriately, sure, the lap belt's going to keep them in the seat. It's going to keep their lower extremities pretty clean and uninjured. But look at what comes to bounce off that dashboard. The head, because they weren't properly restrained. Seat belts are huge as far as protecting you in a crash. They keep you in the vehicle, they keep you restrained in the vehicle so you don't really bounce and smash around off all sorts of things inside the car. It is really the best protection you have in any type of significant crash. Next, we'll talk rear end impact. Rear end impact, we expect the patient to be propelled forward, especially if they were at a stop. So whatever comes along and hits them in the stern of their vehicle is going to push them forward. So they are likely to go forward and hit their chest off the steering wheel. They are likely to go forward and hit their head off the windshield or dashboard. We're likely to see some lower extremity injuries, so ankles and tib fibs getting kind of caught up and broken up in the pedals. We could even get pushed forward with enough force to start talking about those knee and hip and pelvis injuries again. And then they're going to be propelled backwards when the car stops moving and after they strike the objects inside of the car. And that's where we see a lot of those neck injuries with our, whiplash, which hyperextend the anterior ligaments and spine ligaments in the neck and really stretch things out and tear and possibly fracture. So the injury patterns with a rear end impact are just as significant and every bit as much of a mixed bag but just knowing the way that all of this kind of works and fits together will help us figure out the wheres and what fors. Lateral impact, we still have the same forces applied. We have the direct impact of a vehicle striking right on your door. It pushes you in towards the middle portions of the vehicle. You can hit the sides of your head more often than the front and back of your head in this type of crash. But think of the 40 mile per hour, half ton or more vehicle that is hitting you directly. So on the side that takes the impact, we see, the entire side of the body receiving that force and really getting a good working over from whatever hit that door to cause the patient to be propelled towards the middle. And lastly, as far as vehicle collisions go, rollover collisions. Rollover collisions, if you look at this bottom picture, it looks an awful lot like our patient is in a washing machine. This is showing you an unrestrained patient being tossed all over the vehicle, and every single time his body comes to rest against some immovable object inside of that vehicle is a new set of collisions. We will have just injuries galore and injuries everywhere to someone who is an unrestrained passenger in a rollover collision. Add to that, every single time you're involved in a collision, things inside your vehicle, if you're hit hard enough, actually become projectiles. So every time this car on the bottom here is rolling over with our friend unrestrained and getting tossed all over the place, things are getting dumped all over them. Books, papers, coffee cup, groceries, you name it, pens, pencils, anything that's in there begins to sort of get a bit pokey and can really cause some increased injury. Vehicle pedestrian is getting a whole lot more common these days. Auto pedestrian is significant impact. It's going to depend on how far or how fast the vehicle was traveling, how much of your patient was hit or run over or thrown. If a patient is hit and thrown, you also have to remember that after being thrown, that they're going to hit the ground as well. We see a lot of very specific injury patterns when kids get hit versus when adults get hit. Most of the time when an adult sees that they're going to be run into by a car, what do you think the adult does? What do you think their normal reaction is?
They lock up.
They either lock up and get squished or they start running. So we'll see a lot of like hip and lateral injuries, some lower extremity stuff, but normally we'll see an adult who is trying to boogie to get out of the way. Kids, on the other hand, have that whole like deer in headlight reaction. And a lot of the times when a child is about to be hit by a car, they turn and face it and almost like open up their arms and look right at it because they're scared and they panic and they freeze and don't know what to do. Add to that kids are a lot lower to the ground, and we'll start to see some chest and head injuries. Parts of the upper body now are being run into because the kid has just turned and opened themselves up to it, and we'll see, anything from the abdomen straight on up. And then as they get hit, their head comes down and also hits either the bumper or the hood of the vehicle. So it helps us to sort of take a look and predict a bit of the injury pattern there as well. Now, we talk about restraints, and restraints are great. Being in the car and being held in the car, that's fantastic. Not hitting all of the things and bits and pieces that are all over the vehicle, even better. But why do you think this whole slide is mentioning things called hidden injuries from a restraint?
Because you are still impacting on something. It might not be the steering wheel, but you're impacting on the restraint system.
Yep. And you know what? The restraint system is meant to be snug. So, I mean, sure, you're not traveling as far or necessarily hitting as hard, but you are still sitting and hitting. But let's talk about the fact that a lot of people don't wear these restraints right. Look at figure B, that picture right there. The belt that is supposed to go across your lap is called a lap belt for a reason. Look at the positioning, and now look at some of the bruising on this patient. Was the lap belt across this patient's lap?
No.
No, it was across the lower quadrants of their abdomen. And none of the things that live in the lower quadrants of your abdomen really appreciate that kind of force being applied to them. So improperly worn seatbelts are every bit as bad as not wearing a seatbelt altogether. Put your lap belt across your lap, put your shoulder strap in the correct position across the bony portions of your upper part of your torso, and they won't cause as much damage because it gives that belt something to grab against. If people are wearing their seatbelts incorrectly and have it over, more padded, more cushiony, more easy, more places that are probably arguably more comfortable for them, we're going to see that those restraints are actually causing injury. My patient still might actually strike things in the vehicle if they're, they do the, and this is one that I don't understand. They leave the lap belt where it's supposed to be and they take the shoulder strap and put it behind them. So, all right, I'm still buckled in. Yeah, but you know what? The important bits of me are going to get all smashed up by hitting the steering wheel, hitting the dashboard, letting the airbag come out and just blow my socks right off when it comes out of the car at a couple 100 miles an hour with a couple 1,000 pounds of force because it's a miniature explosion going off in front of your face. Yeah, airbags are great. They're meant to keep me from hitting hard things, but it's also like getting hit with a bag of sand right dead in the face until it starts to deflate.
You'd think that probably older folks would do that just because my first car didn't even have shoulder restraints. It was just a lap belt.
Right. I worked with a guy who he didn't like listening to the seatbelt thing ding at him in the ambulance. So he would get in the morning, and I never liked to drive the first call. I always text the first call. I don't know why, but I did. And he would take the seatbelt and clip it behind him and then get in the truck. So not even the lap belt, not even anything. So he didn't have to listen to the truck yell at him. He just took and clipped the thing behind him.
My parents do that.
And it's like, oh my Lord,
I
especially
tell them not to. But
like that windshield's not meant to give. So when you see at a motor vehicle collision scene that spidering of the windshield, and you can see the only direct point of impact had to be that patient's head, there is going to be massive and significant injury going on there, just based on the amount of force it takes to break a windshield. Even just make it crack. Now, let alone if they were to actually put a hole in it, holy buckets. I mean, we're talking just astronomical amount of force being applied to the patient's head, and that's a partial ejection. So it really ratchets up the, oh man, this patient's probably going to die. Even properly restrained people in a motor vehicle, so now we'll get away from talking about, lap belts and lap and shoulder belts being worn inappropriately. Airbags aren't really super helpful to them because they're awful close to them by the time it goes off. But even if you're properly wearing your seatbelt, that airbag is still going to get you. When we do the driver training class, we'll talk about proper hand placement now for the way airbags are. But airbags are still likely to cause some possible facial fractures, bleeding, burns from the powder, burns from the airbag and causing friction just coming out as fast as it does. Airbags in the front are great for frontal impact. If you don't have a car that has those side airbags, they're not so great for lateral impacts. You're still taking a pretty big amount of the force involved with smashing up a vehicle. So a properly fitted car seat will restrain a child in at least 3, possibly even 5 points. The parts of the body that aren't restrained continue to move forward. So the head is going to continue to move forward and snap around. We'll have some neck stretching that will really be uncomfortable for the patient, and possibly some injury to the vertebrae and the spinal cord itself, because they're all more pliable in a child. Doesn't matter if it's front or back facing. Airbags will really do a number on children. Kids shouldn't be put in a spot where an airbag is likely to get them, if at all possible, to be avoided. Next, we're moving on to motorcycle collisions. Motorcycle collisions are they account for a significant number of motor vehicle collisions on the highways, especially. The morbidity and mortality of motorcycle collision. So morbidity means illness and injury, and mortality means death. When they study that, the amount of illness or injury and the amount of death is significantly impacted by, was this person properly outfitted? So was this person wearing a helmet like they should be? I've ridden a motorcycle for almost 20 years, and I won't move mine without putting my helmet on. Not because I'm worried about me, it's because I'm worried about all the people around. So did this patient properly take care of themselves in the event that something wild and wacky happened? Motorcycles have the same sort of injury, the same sort of impacts as any other collisions. We have head-on. Really, just about any motorcycle collision at all can sort of be considered an ejection. Head-on impact occurs when the bike goes forward. So the rider travels up and over the handlebars. I've seen people hit and break both femurs on handlebars alone. The injury pattern from there, depending on what they land on, what they hit in the meantime, motorcycle injury patterns from collisions are very, very difficult to discern. So we go where our signs and symptoms point us. If it looks like a significant mechanism of injury, we are going to check the everywhere. We look for that decap BTLS. We look for crepitus. We poke and prod and palpate everywhere just to make sure that we're not missing something significant, missing something important, and causing our patient any undue harm. So I mentioned fall, and I mentioned the direction of travel and our patient landing on their feet. Injuries for an adult for a fall of more than 20 feet is going to be a significant mechanism of injury. When our patient lands feet first in this fashion, the energy is being transferred directly up the body. That transmits straight through. So we'll see not just injury pattern where the patient actually comes to rest on the ground where they hit. We can see some injury to knees. We can see injury to the hip, pelvis. We'll see a lot of times what they call burst fractures in the spine, which means the vertebrae just essentially sort of explode a little bit. Anybody who falls from that height is very likely to have some sort of spinal injury, and it's really on us to take care and make sure that we are assessing appropriately. When a patient falls head first, well, it's called head first for a reason. The head is normally the primary source of impact. It depends on what the patient did to try and slow themselves down. A lot of times, patients will put their hands out first. So we'll see wrist and arm injuries, maybe some shoulder injuries, but eventually the old coconut comes to rest on the ground somewhere in a less than fancy fashion. We can see hyperextension to our patient's neck, like in this bottom right corner in the whiplash, or hyperflexion in this patient who has a compression injury from diving. These are two very, very significant injuries right here, because the spine does not like hyperextension or hyperflexion. It does not really manage these things well. It doesn't like to be compressed. The spine is pretty well rooted and it is pretty stable through most things, but stretching forces and compression forces really are not good for the cervical vertebrae, the thoracic vertebrae, the spinal cord in between. I have a friend who has a compression injury from diving into a shallow pool, and he's been in a wheelchair for going on probably 30 years because of that. Once these injuries happen, a lot of the times they are permanent and long lasting and very much life altering. So next we're talking penetrating trauma. Penetrating injuries, when we talk a low velocity injury, that is generally person driven. That is something that was taken by one person and pushed through the body of another person. Knives, anything you can think of that a person can use to sort of poke another person is going to be considered a low velocity injury. We can have actual stabbings. We can see things like slash marks on hands and arms from defensive injuries. Generally, the depth of the injury is limited to the length of the object, and the area damage is also limited to the length and width of an object. Depending on where a patient does get this low velocity penetrating trauma is going to tell us what underneath may be injured. If my patient's stabbed in the chest, I start thinking pneumothorax, hemothorax, cardiac tamponade, all these things that will cause not only volume problems, but also may lead to things like obstructive shock from a tension pneumo or hypovolemic shock from bleeding into the chest. We'll talk at length about this couple of different signs and symptoms we can be on the hunt for to see which kind of shock this patient's going into. But at the end of the day, just recognize the fact that they're going into shock and treat them appropriately. Moving on to the next little bit, we have medium and high velocity injuries. Medium and high velocity projectiles are bullets. They say shotguns and handguns are generally considered to be medium velocity. Medium velocity bullets generally don't have all the same problems as our high velocity projectiles. Now, that is not to say that this is not going to be problematic for our patient, but if you look at the picture here, you have what we call cavitation being depicted for you. And you see this extra wound cavity right here, right? You see the little like oval shape. That is the pressure wave of that bullet passing through the tissue. Our medium velocity impacts have a much smaller pressure wave. So that pressure wave causes what is called a temporary wound cavity. That's that cavitation, and that temporary wound cavity expands and then contracts down, and the trajectory and path of the bullet actually causes a permanent wound cavity, so it leaves a tunnel. But all of that tissue that was in that temporary wound cavity, that big expansion and then contraction, is still going to be damaged. So there's likely to be lots of bleeding, likely to be lots of soft tissue damage. There's likely to be some destruction of bone, but it's on a smaller scale because the actual velocity and energy transfer is smaller. And then if we look at the temporary wound cavity created by our high velocity projectile, we have all this area of tissue that is either temporary or permanent. So that if you look at the picture, the size of the projectile didn't change, but how fast it is being propelled forward did. And we see a much bigger temporary wound cavity, and we see much more bone destruction. We see much more tissue damage. We'll see probably likely to see a lot more bleeding, and it's just based on that energy transfer. Our exit wounds with a bullet, since we have a whole bunch of tissue being torn and being shredded, and we have a whole lot of stuff being now propelled in front of that bullet, the exit wound is likely to be much, much larger than the entry wound because it's now blowing all that tissue out the back end. Every time somebody is shot, the bullet does not go through and through. It depends on what they were shot with, what part of their body it hit. Did it bounce off of anything inside? So you won't always have that stereotypical that everybody thinks of like entry and exit. Sometimes the bullet will go in there and play ping pong for a little bit, and they could wind up in complete other portions of the patient's body. Just know that the injury is even more significant and even more widespread than just the tiny little hole that you can see, because a lot of tissue underneath has been damaged. And I'm actually going to show you a video right now that will actually depict that for you.
We're giving away our $50 shoulder holster for free. You just pay the shipping. No hidden charges, no recurring fee.
All right, here we go.
What's up, everybody? My name is Scott. You're watching Kentucky Ballistics, and it's Full Auto Friday. And today we're going to shoot some ballistic gel again. We already shot some ballistic gel with the MP5. We used full metal jackets. Then we shot some ballistic gel with the AR-15, and we used full metal jackets and hollow points. You said you wanted to see some hollow points out of the MP5, so that's what we're going to do today. By the way, I want to let you know we do have a new Full Auto coming for the channel. Hopefully it'll be here pretty soon. I'm hoping within the next month. It's just rolling a little slower than we wanted it to, but when it gets here, you're going to be really excited. I know I'm really excited about it. So the hollow points we're going to use today is some Hornady Critical Duty 9mm flex lock, and these are 135 grain. This is what this looks like. You see here, you got your little red tip there. That's what we're going to use in the MP5 today. We're shooting ballistic gel again, but we have a pretty cool target for today. Let me go get it real quick. Oh, it's heavy. Oh, it's heavy. Okay. This is our target for today. We have a clear ballistic torso. This was sent to us by Clear Ballistics. A huge thank you to Clear Ballistics for sending us to it. Thank you very much. I am super excited about this thing. We're going to break it in today with the MP5. And then, of course, I have more plans for this ballistic gel torso. We need a name for this thing. So if you have any suggestions, leave it in the comment section down below, and maybe that's the name we'll use. Let's go get this thing set up. It is really heavy. I want to put it down. Yeah, that ain't gonna fall over. Okay, we are ready to go. We've got our ballistic gel torso set up. We're about 10 yards back. We've got the MP5, and I've got two 30-round mags ready to go. I also wanted to mention to you, if you don't already know, I've started a second channel called the KB Life. It's going to be a place where I can post stuff that I don't feel would fit on Kentucky Ballistics. I want to keep Kentucky Ballistics pure. I don't want to start mixing in other stuff. So other things that I want to show you, other things that I want to film, I'm going to post them to the KB Life. So be sure and check that out. I'll leave a link in the description down below. Normally, I try to keep all my shots in one little group, but today I'm not going to do that. I'm going to try to spread them out today because I don't want to just chew up one little spot on this torso. I kind of want to spread them out. All righty then. I don't think any of them stays inside it. Let's go check it out. Nope, it all slides right through him. Okay, let's hit him with the second mag. This time I'm going to try not to move around so much. We didn't hit him as many times.
All right, that guy's camera stinks. What you'll see in videos that slow it down a bit more, he just wanted to play with his guns apparently, is you'll see, come on computer, there we go. You'll see a great big opening in that ballistics gelatin as the bullet's going through, and then you'll sometimes even see a bit of a small explosion as it breaks through the other side, and you can see just the tissue damage internal is absolutely astounding sometimes. Where gunshots are on our person is going to be what defines them as really significant or critical versus not. Now, that's not to say that people who are shot are not injured, right? But what we're thinking is, how injured is this person? How bad are the injuries underneath that I can't see? And how high should my index of suspicion be for this patient to take a pretty negative, pretty nasty turn right here in front of me? And what can I do to deal with that? Places that house things that are super important or super vascular. So head, obviously the computer is up there. Gunshot wounds to the head are not good. Chest, we have heart and lungs and great vessels. We have gunshots right along the midline. You saw that a very common round fired from that gun, a 9mm. So those were going right through a ballistics gel target. Those ballistic gel target are engineered so it is showing you just what that bullet is doing to a person. So you start thinking, all right, the lungs are getting pretty chewed up if somebody's been shot in the chest. The great vessels are possibly injured. The heart may have sustained some direct injury or some cavitation injury from that bullet passing through. And you start to think, all right, we're getting enough negative checks in our book here to say, even if this patient presents to me well, he's not. Even if this patient presents, that, all right, yeah, I've been shot, but they're maintaining and they're compensating. That's not long for this. This is not a situation where, if somebody's been turned into Swiss cheese and has holes all in them, that they're going to continue to compensate and continue to do well. The abdomen, we have the same problems because the GI tract itself, the gut has that mesentery artery, those mesentery veins that sort of are a mesh network around all those GI places. So we can have a lot of vascular compromise. And then think of all the things that are housed in the lower quadrants of our abdomen, all of the bacteria and nasty, gross stuff that can be leaking out into our patient. Or then think of the upper quadrants of our abdomen that has very, very vascular, very, very blood-rich organs, that if we start having holes punched in those, we're going to have a whole bunch of bleeding problem and maybe find some pain, some rigidity, some distension, because our patient is losing a lot of blood that's staying inside. Blast injuries, well, blast injuries are a mixed bag as well. Blast injuries, we have multiple injury patterns because there are 4 different types of things that are going to cause you injury in a blast. The first being the explosion itself, possibly blowing bits and pieces of you right off. After that, we have the pressure wave that follows. It's pretty closely shortly after, but that pressure wave is now not only limited to the explosion directly causing injury. That pressure wave is going to rupture things that are hollow. That pressure wave is going to pass right through and possibly cause some pulmonary damage, some damage to the hollow structures of your GI tract, or even your diaphragm is susceptible to pressure wave. And then after that, we have the secondary injury caused by all of the projectiles being propelled by that explosion. So now we have things penetrating the body. And then last but not least, once this explosion knocks us off of our feet and propels us into something, we have what is the tertiary phase injury, and that is us coming to rest against something that didn't want to move in the first place, and our body hits it, and we have even more injury from being propelled at an explosive rate of speed from that explosion. There are just, it's innumerable, the amount of injury that can be caused during an explosion. So isolated trauma is easier to deal with. Isolated single traumas, you know, our patient that we talked about earlier who fell and had the isolated wrist fracture. All right, we're not super worried about that person turning around on us and, you know, up and dying, because, well, it's a wrist fracture. People break their wrists every day. You'll probably be okay. About 90% of our trauma patients only have a simple or single injury involving only one body system, and we're not super concerned with a lot of that. You know, a fractured tibia or a soft tissue laceration with no major bleeding, those are our isolated injuries. Those aren't super concerning. Patients with a multi-system trauma, so now we have trauma that's spread out throughout the entire body a lot more, they have a high incidence of morbidity and mortality. That means they have a high incidence of either A, becoming very sick or incapacitated, or dying. So what do you think multi-system trauma has to do with? What do you think that means?
So like a trauma that happens to your circulatory and like respiratory.
You're right there. So we don't even have to limit it to specific things that we've already, and I know I've beaten into you guys, circulatory, respiratory, airway. I get it, and that was a great answer. But it doesn't even have to be that significant. Now we're just talking about multiple spots, multiple places, multiple things are being affected by this trauma. Bilateral femurs. Bilateral femur fractures can house a little bit better than half of your circulating blood volume, and not a single drop of blood will have spilled on the ground. That's a multi-system trauma. That is a significant trauma with a very poor prognosis if that patient doesn't get to definitive treatment very soon. And luckily here in the area that we work in, we are never more than really 10 or 15 minutes away from a level 1 trauma center who can take this patient right up to the operating room and get about the business of fixing these problems. Rapid transport to a trauma center is what saves our multi-system trauma patient. We have a protocol that tells us when we transport somebody to a trauma center versus when we transport somebody to the local community hospital, and that is based on this golden period. The golden period is what I've been sort of mentioning to you guys already, is that platinum 10 minutes. We need to assess, treat any life threats, package, and leave within 10 minutes of arriving on scene. That is really what we strive for. That is really what we should be shooting for. And it's going to do the best good for our patient. Because where is all the actual treatment of this person going to happen?
At the hospital.
At the hospital, in the operating theater. So fiddling around on scene and spending time doing things that aren't critical, doing things that aren't really deadly important for this patient means we are stealing minutes from them, because that platinum 10 minutes extends. That platinum 10 minutes is for us. The golden period that we're talking about is what is called the golden hour. The golden hour means if we can have that patient alive and in an operating room within an hour, they are far and away more likely to survive this multi-system trauma than if we did waste their time and spend more time bandaging and band-aiding and ice packing things that weren't really altogether that important, because at the end of the day, this patient will die without a surgeon. Trauma is a disease of surgical repair, period. There's no other question. On-scene activities are limited to the bare bones, bare minimum. Get my index of suspicion sorted out, treat all my immediate life threats, give them a quick once over with my rapid trauma assessment to find the things that can be found, and then we're out of here. And anything else that I need to do can be done on scene, because this patient's going to go under the knife to be appropriately managed. My index of suspicion is looking at the forces that were applied to them, looking at the things that it touched, like the body areas that it touched, and saying, all right, I know I can't tell whether this bone is broken. I know I can't tell whether this joint is dislocated. I know I can't tell if there's some sort of internal hemorrhage or a cardiac tamponade beginning to form. But since I know what force was applied to this patient and what actual bits and pieces live inside of that area, then I should just suspect that those are injured and treat my patient based on my worst suspicion, which is going to be my high index of suspicion. So in Massachusetts, we have 3 levels. We're going to talk about all 4 here because this is national curriculum. So a level 1 trauma center, think places like Mass General, BI, Brigham and Women, Boston Medical Center, Leahy Clinic. They are places where helicopters land to drop people off. A regional trauma center can manage all types of trauma, 7x24, 365. They have every specialty right on scene and can have this patient open and get to fixing things at the blink of an eye. A level 2 trauma center is a trauma center that can manage most traumas. They do have some surgical capability 24 hours a day, but it might not be in the hospital right that second. Level 2 trauma centers have to have the ability to call people in and get them to the facility within a certain time period to provide those surgical cares and some of the interventions and some of the imaging. They don't have to have that doctor right there on scene every single minute of every single day. If they can't get that specialized person in for one reason or another, they have every ability in the world to stabilize that trauma patient and then have them brought up to places like Leahy Clinic, Mass General, and still be within that golden hour, because surgery is what's going to do it. That's really it. A level 3 trauma center, which is again where our whole trauma bit stops in the state of Massachusetts. It's our community hospitals. So like the Melrose Wakefield, the CHA in Everett. These are places that are going to focus on stabilizing this patient and making their transfer to a level 1 trauma center safe for them. So they'll start things like managing their airway. So they'll intubate the patient, or maybe they'll start some blood, and they'll do some things that are going to make it so that this patient will live to make it to the surgeons at Mass General and Leahy and BI and Brigham. Level 4 is generally now a smaller, much smaller level than level 3. It is community hospital in like a remote area. They do just the briefest of stabilization, and then somebody generally probably swoops in on a helicopter and flies them right out to somewhere of more important and more ability. Level 1 trauma centers are not feasible for every single community. You know, we have some of the best level 1 trauma centers right around the corner from here. So it would be cost prohibitive to decide to build one in Malden. It doesn't make sense because Malden is tops in an ambulance probably 10 minutes away from the front door of the Mass General Hospital. So these are put in the places where they're put. These level 1 trauma centers are put to serve a larger swath of the community. You know, we do have Boston MedFlight. Boston MedFlight will come and touch down and have you in Boston, or have you at a level 1 trauma center, say out in Worcester, or one of the other places where they will actually land and drop people off in very short order. And really, time and amount of people available is the reason why it's not something that every hospital strives for, because it's just not sensible to turn every single hospital into a level 1 trauma center. The people that are responsible for running level 1 trauma centers don't grow on trees. Our big ticket items here for our trauma patients. First of all, scene safety. As always, scene safety. You know, whatever injured them still has the ability to injure you. Have a very low threshold for, do I need some additional resources? You know, make sure you have the people on hand or have the people on the way that can make this scene as stable and safe for you as humanly possible. We're doing our primary assessment right away, same as always. We're going to do spine stabilization the minute we get to that patient's side. Start forming our general impression. Make sure we have a patent airway. Make sure we have adequate oxygenation and ventilation. If we don't, we fix those things. We're going to treat for shock. We're going to make sure that my patient still has adequate rate, rhythm, and quality of their pulse. We do all of those things right out of the gate because they're primary problems. And if my primary problem is a problem, I fix that right there, right then. I move into my rapid trauma, and after my rapid trauma, we occupy, we package, and we get the heck out of there. Because really, this patient needs much higher level of care than we are going to be able to offer kneeling in the middle of the road. Special considerations, airway management and ventilation for sure. Remember that for our trauma patients, X begins the letter the alphabet here. Exsanguination is first. It takes less than 2 minutes to bleed to death. It'll take 2 minutes to assess and treat airway, breathing, and circulation problems. Make sure we lock in that primary assessment. Make sure anything and everything that can be done to ensure that those vital functions are being accomplished by our patient. And our goal should be rapid transport. And our goal should be rapid transport to somewhere that can provide the adequate and most good for this patient. We're going to take them to the closest appropriate hospital with an ALS intercept en route. And then this bottom bullet point, don't get tunnel vision. What do you think that means? What kind of things might cause us to get tunnel vision on a trauma patient?
If you walk in and you see them bleeding from their leg, you don't want to ignore the rest of them.
Yeah, that's one of the biggest things we can run into with a trauma patient is you walk in and you go, oh man, that's yucky. And then you focus on the thing that's gross. And you completely and totally overlook the fact that they have an unmaintainable airway, or they're in respiratory arrest, or they're getting ready to go into cardiac arrest because they have a weak, thready carotid pulse and they're, gray in color. But you stay focused on that leg that's like pointing in wrong directions and all twisted and bent up. And it's just, that grabs your attention because it's difficult and nasty to look at. Like I said, everybody's got their thing, and that's not my favorite. But you have to make sure we dot our I's and cross our T's and make sure that we do the things to keep this patient alive, stay within our platinum 10 minutes, and get that patient transferred to somewhere that is going to be able to correct their problems. All right, folks, that was our lecture for today.